Good morning. Good morning. Good morning. Want to welcome everybody to the 22nd Annual Sports Medicine Update. Thank you all for being here. I was talking to Bob Marley earlier. I guess the first Sports Medicine Update 22 years ago was at Minute Maid Park with 75 people. And now today we're the folks in this room, and we have people online from, I think, 29 states or something like that, Bob? 29 states, and actually sold out our registration at 500 people, so we've grown quite a bit, and we're proud of that, and we appreciate y'all being here. I'm Keith Jones, by the way, the Outreach Director for Memorial Hermann, and from last year to this year, we've done some really cool things. I mean, some growth within our business, and hired some really good people to take some spots, and some people to take some new spots. So everything's going well. We're trending in the right direction. I appreciate all the things you do. I want to introduce our first speaker, Dr. Lowe, Walt Lowe. Dr. Lowe is the medical director for Memorial Hermann Rocket Sports Medicine Institute. He's also the head of the faculty for University of Texas Health Science Medical Center, Department of Orthopedic Surgery. I would go through a whole list of his accolades and affiliations, but we're short on time. I think the big thing that we all need to know is a number of years ago, 93 or somewhere like that, Dr. Lowe moved to Houston, and he started outreach here in the Southwest region, Wharton and places unknown past there, and with Bob Marley and a few other people. So he is a huge reason why we're all here, and great doctor. A wonderful guy, and besides that, he's a really good friend of mine. So without taking up too much more time, I want to present to you guys Dr. Walt Lowe.
That's not me. You're good, and I'm just pulling it down off the screen for you.
Okay, got it. Well, thanks for having me again. It is crazy how fast time goes by, and I think Bob and I have been working together for 25 years or something like that. It's just crazy. And, I always, when I come out here, I get to see faces I haven't seen in a while. And, Bubba, congratulations on the SWATA Hall of Fame. I promise I didn't tell too many lies in my introduction for you, maybe just a few. But, and so I don't know, it's just amazing how this has grown. I hope you guys understand, and I think you do, how important you are to guys like me. I mean, I've spent my whole career taking care of kids that get hurt on fields, and the first interaction always comes from you guys. So I would just, when you get old, you get philosophical, and luckily you get smarter. I think as we go, and, I always hear a bunch of positives about the interaction, but I would of the player and you guys, but I would just be careful. And something I learned a long time ago is that when an injury happens, the game doesn't matter anymore. What the coach thinks doesn't matter anymore. It really matters, and you guys know this, a lot to the parents. And the parents are going to come away with their initial trust in the whole process from how you guys handle it, not how we do. And so just take care of the kids and do the right thing. And if they can't play that day, they can't play that day. And if they can, they can, and everybody's trained to make those decisions. But it just amazes me. And I think this being in 29 states and all that is just awesome from where it started. And I remember that first deal at Minute Maid where it got going. So it just speaks to how cohesive the athletic training community is, because there's a bunch of guys that have jobs today and conditioning camps and all that kind of stuff. So I think it's just amazing how this has happened. So I wanted to talk about something that most orthopedic sports medicine guys don't even know about. And so don't ask Meeks and Camarillo, because this will be news to them too. I hope they were showing up for the lecture, you know. But what, you know, from me, the main way my practice has grown is with the kids that tear their ACL, you know. And I've been lucky because I love that population. I love that science, and every year you hear, well, we already know everything we need to know. This is what's going to happen, and I'm telling you, we're not even close to knowing what we need to know. And when you do a bunch of them, and I do 300 or 400 a year, you see a few that fail, and every one that fails, you lose sleep over. You know, it takes years out of their life. It takes dreams away from them that you hope they get back and all that. So I think my biggest concern in my last 10 or 15 years, praying I don't get hit by a bus, is to try to really decrease the number of failures. Because when you look at the reality of ACLs failing out there, and you look at a 5-year snapshot, because you guys may see them in high school, and they may their next one or the same one again until they get to college. You don't always get to see them, you know, back to back from that standpoint. But if you really dissect the numbers, there are probably all comers between 20 and 30% that either fail or tear their other one within the first few years, you know. And so if you do the math on that, there's 400,000 acute ACL tears a year, and a failure of 20% of those, all of a sudden you're going, oh my God, there is 80, I mean, just thousands of re-tears of ACL. So anything we can do to prevent, you know, the re-tears from happening. And so I'm not going to talk about the things that you guys already know about and things that we've, you know, been talking about forever. But the risk factors of, you know, the young girls are the highest risk. You know, they have the anatomy of wider hips, narrow knees. The physics equation isn't as good for them. We know the hormonal influences, but we can't really change them. You know, a lot of them have really narrow notches. And what we are going to talk about, and you'll hear it over and over again, is this posterior tibial slope. You know, the younger you are, the higher risk you are, the higher risk you are of re-tearing. The hyperlax ones, the higher your risk you are. We know all the neuromuscular things that we can change from sports metrics or FIFA 11 and all that. And then when you return to soccer and football, I'm sorry, the risks are high. And if you look at it, girls soccer is number one. That's no news to anyone in here. Boys football is number two, and then girls basketball is number three if you're looking at the teenage age group and how they fail. And those numbers down at the bottom are per 100,000 exposure. So practices, games, you know, all that. So there is a fair number. We know how this does work. We do know that in football, sometimes, you know, this kind of stuff just happens. And whether it's contact or non-contact, it's terrible. It's these girls that I think if we focus on some, we can prevent not only a bunch of tears, but a lot of the re-tears, you know. I think when we're dissecting down how things fail, so graft choice, you know, I don't care what anybody says. I've been a wave, and you guys have heard me talk about patellar tendons in here and hamstrings in here, and I think quad tendons in here a couple years ago and all that, and I'm sorry, nothing holds up to what the patellar tendon grafts do right now. I wish they did. I mean, we had, you know, I presented at AOSSM last summer or two summers ago with a match control study of about 50 quad tendons versus patellar tendons, and they were equal. Pretty much a 0% failure rate on both. When we got that number to about 150, now the quad tendon failure rate is 4%, 4.5%, and the patellar tendons are still 1.2%, you know? And so the same thing happened to the hamstrings. We were enthusiastic about them. They did great early on, and then the tears started to mount. And when you think about it, they're all soft tissue grafts. We're asking soft tissue or tendon to heal into bony tunnels, and that's their weak link. So one of our focuses has to be, if we're not going to use grafts that put bone in bone tunnels, we have to be able to control the healing, not only of the graft itself, but the healing of that graft into the bone tunnels. And that's the reason all these grafts are great. The problem is they don't all heal the same, and that's why the failure rate of all these other grafts we've come up with continues to be higher than the patellar tendon graft. Bad surgery has always been probably the number one cause. It's still in this country. 80% of the ACLs that are done by people who do 10 or less, and that's not going to change. You know, bad clinical decisions are a big part of re-tear. The main one of that is returning people too soon before they're ready. And it's interesting, before return to play testing, 6 months looks great, quad looks awesome, running like a deer, great, you're released, you go back, you go play. And the failure rate of patellar tendon grafts then was about 9%. Same kid, same time frame, passes entire return to play test, has a high ACL RSI or psychologic profile that says he's competent. The re-tear rate's 1.2%. You know, and so we never use, for a long time, we never used objective data to say, yeah, you can protect yourself with your own muscles, you know. And so just incorporating that objective data, you protect a whole lot of kids when you let them come back. And when you're ready, and when you're not, you're not. You know, I think that's not even considering the healing, the time frame, anything else. Now, it takes them, you know, the real elite stars may pass it at 6 months. The real numbers are usually out at 7.5 or 8 if they truly are over 90% or close to 100% on everything on a return to play testing. And then we keep getting back to this increased slope, you know. And so that's really what we as surgeons have ignored over the years because it was just them, you know. And so slope has become a well-known factor for failure of ACL grafts, okay? It is a risk factor, and I'll get into it in depth in a minute and quit saying everything twice, I guess. It is a risk factor for tearing your ACL, but there's just not enough numbers, and the focus hadn't been there long enough to say it's one of the primary reasons they fell. But when you start looking at posterior tibial slope, in the population of torn ACLs that come, it's high in a whole lot of them. So all of these things we've talked about, hyperlaxity, return to high-risk sports, you know, all female, you know, young soccer players, all that, some protection is important. And the thing that's being done more and more is called this lateral extra-articular tenodesis, which is where, and I had a video, but I took it out because it's just too long. It's where we take a small strip of the IT band, about 1 centimeter wide, in sort of the mid portion of the IT band, and we transfer it over to the femur in a pretty isometric position. And what it does is it shares load with the ACL. And so it has been shown to be a big protector, and I'll go into it a little bit in a minute. But when it's been added without considering slope, you know, they published in Sweden that it decreases the forces through the ACL graft by 43%. You know, I just still think it's questionable whether this LET is going to protect kids from slope, and I'll get into that in a little bit. But if you look at the Canadian Stability Study, the Santi study out of Lyon, France, and all of that, in hamstring grafts, the addition of a LET in all comers decreased the tear rate by 50%. So a significantly lower number if you added that protection to a soft tissue graft, and I already gave you a little history about those grafts. So the indication for it are, like I talked about, revisions for sure, high-grade laxity. So kids, you examine their knee and it pivot shifts right there in front of you, you know. The really hyperlax kids with 10 degrees of hyperextension or more. And then I believe every soft tissue ACL graft should probably have a LET with it to protect it. So that would be the quad tendons, and that would be the hamstring tendon grafts. And I'm not going to tell guys don't do those grafts. I think they're good grafts, and I think all of them are adequate choices. There's none of our grafts that are perfect. Where you shouldn't do it is if there's going to already be big surgery on the lateral side. So big, you know, posterolateral corner injuries, lateral collateral injuries, those kind of things. It's too much to add that, and they'll get stiff, that group. And then if they already have lateral compartment arthritis, and hopefully none of you guys see that group, you know, you can increase the pressure across that. We don't have any evidence that it causes that, but if they have it, it can make it more symptomatic. So now I'll get to slope. And so I don't know how much time I have, but all right, just to keep talking, Bob. You know, so despite all of these efforts, like I said, the failure rate's up to about 30% when you really start looking at it. And there is definitely a strong linear relationship between slope and the force on the ACL and on ACL grafts. And really any tibial slope above 10 degrees, and I'll show you that the forces go up. And for every degree of increased posterior tibial slope over 10 degrees, the forces in the ACL go up by 20%. So if normal slope is 8 to 10 and you have a 15, it's 100% more stress on that graft than it would be if you had a normal slope. And you know that's why I just look in the mirror and go, duh. You know, why did we ignore this for so long? So you can see on this graph, really as soon as you start to get into the normal range, it just goes up and up and up, you know. And so a posterior slope greater than 10 degrees on a long leg lateral x-ray is 5.7 times higher risk for graft rupture and for tear of their other ACL, okay? So that knowledge alone should make us all pretty uncomfortable, you know, of how we're taking care of these kids and what we can predict from happening. And so we have a real dilemma because what we can't prove, and we're actually trying to prove it right now in our biomechanics lab, is does this LET, which is really easy to talk people into. I mean, if you say, hey, listen, I can decrease your daughter's tear rate by 50%, they say do it. You know, it's not a long discussion from that standpoint. But when you start having a discussion about cutting bone and flattening it out and putting a bunch of plates in and that kind of stuff, most of them want to get up and run out of the room, you know, because that's a whole different deal. But I may make a case here for you today that we probably need to be doing a whole lot more than that. You know, you can see the depiction, you know, just of these, you know, how the forces, you can just visualize it like that. And it's a good way, these pictures like this on your left here, of just explaining the more the slope goes up, the heavier that ball gets and the more it's going to tear the ACL. So does this LET protect from high slope? And the answer is, I don't think so. Good paper out of Vail last year that I think needs to be done a little better showed that it decreased the forces in the ACL by 8.3% no matter what the slope was when they compared it to slope. So a slope of 12, it helped 8.3%, and a slope of 15, it helped 8.3%, a slope of 20, it did. So the higher the slope, the less the LET does, even though it's one of the primary indications in this country to do it. I think we're going to find that it doesn't do a lot, and it doesn't decrease the tear rate for sure by 50% in high slope people. I'm not even sure it changes it at all, just don't have those numbers yet. These are some x-rays to look and just show what's done. So the thing that decreases the forces is the slope reducing the osteotomy that you see here, the pictures where this slope, this is compared to 90 degrees, so this is a 19-degree slope. That ACL is going to probably tear. This is just a picture of how we template and measure that cut and then what it looks like afterwards. And in this athlete, we return the slope to about 5 degrees. So I know everybody's out there thinking, oh, crap, can they ever come back and play after that? You know, and that's the reason for this talk is I'm going to show you some stuff. You go, holy crap, they can, you know. And so this is and I think we're leading in the country in this. I've already started talking all over the place because it's sort of, you know, the first guy through the door gets his nose bloodied, that comment, you know. If you want to change these tears in these kids, then you're going to have to take the step to embrace this, because I think it's the one factor we have ignored over time. So, you know, a simple anterior closing wedge heals very, very quick. We've chosen this infrapatellar route that Alfred Mansour and I do them because it doesn't affect the patellofemoral joint. I think that's very important in function of these athletes, and it has very rapid healing. There are times that there's not only high slope, but there are big varus bow-legged knee or a big valgus, you know, knee, and those biplanar corrections are a very different animal, and I'll show you this in just a second. But you do have to correct all that at the same time if you want to reduce the stresses into the grafts that we're fixing. So this I just presented at the Herodica Society, our big sports medicine society, literally 2 weeks ago. And this is looking at our first 24 slow-producing osteotomies and comparing them to a matched control group of primary ACLs and revisions that match the same. Just to start the discussion, we presented it at the Combine last year, all that of, can you address slope and still return to elite level of, performance as an athlete. So I've already shown you that slide. And so it is a common belief around the NFL, around D1 football and everything else that an osteotomy prevents you from moving on to the next level, okay? No player's ever been drafted in the NFL after a slope-reducing osteotomy. We had one from A&M for a varus correction with the osteochondral transplant that made it into the NFL last year, but he was cut after the preseason by the Cowboys. We don't understand the clinical and functional outcomes yet, and that was the reason to do this of these slope-reducing osteotomies. So I'll kind of show you the numbers. We're at 63 in our database right now, but this was from our first 24. So this is the example I'll give. This is a 19-degree slope. And the purpose of this was to compare the functional performance and graft re-injury rates in patients undergoing ACL with a slow-producing osteotomy to match controls. And so I won't bore you with the specifics of the research. Things we measured were all the usual return to sport outcomes, not just these four, eight different ones in these groups. We looked at SANE scores, self-reported function, all the injury surveillance of graft re-injury, complications, all of that, and then looked at their return to whatever level of sport they were at. So when we started looking at it, demographics, we were surprised because they thought they'd be the same between the two groups, but the people that required were a little heavier. I don't know if that was statistically significant. I don't know if it matters, but it was significant. It's important to sort of look at these demographics because 83% in both groups were already a revision surgery, one-time revisions, two-time revisions, sometimes three-time revisions. The average slope in the slope-reducing osteotomy group was 17. The average slope in the non-osteotomy group that was match control was about 11. They almost all of them, or over half of them, had just slope reducing. About 40% had these biplanar. The grafts were different in every case because I was afraid of doing this infrapatellar slope-reducing osteotomy and harvesting a patellar tendon graft at the same time because you're just afraid of creating fractures you don't want to have to handle. So the graft choices were all over the board. These were big procedures. Even a few of them had osteochondral transplants at the same time because failing an ACL almost guarantees you're going to have something bigger come along with it the second time too. And when you failed it multiple times, some of these are just horrible, So the real things that we wanted to see, so the return to sport in months, if you took all comers, the slope-reducing osteotomy group took almost 15 months, and the isolated ACL group without it only took about 8.5, which is sort of what we're used to. That was statistically significant, and the ACL RSI was significantly lower, and that's the measure of those athletes' confidence when they come back. And so I saw those numbers that Lane produced, and I was getting ready to go give this talk a couple weeks ago, and I said, that just doesn't make sense to how they look to me. And so I asked him to divide it up because these osteotomies are done sometimes in one stage with the revision ACL, and sometimes there has to be osteotomy, bone grafting, other things done, and then a second stage, and this was all comers. And so so I asked him to dissect those out, and when we did that, it's interesting, and then this made sense with what I saw, in follow-up, that if it was a single stage with an osteotomy, their time to pass return to play was about 9 months, okay? And that's pretty normal right now in this. And a primary ACL with nothing else, if you really look at these kids and when they can actually pass this test, the average was like 8.4 months, you know. And so if you looked at the staged ones, you know, 17 months. So if it's a two-stage procedure, it is a big deal, and it really delays their ability to return. Same thing, MARC score, which is kind of our best score for function afterwards, still stayed pretty low in those that had staged procedures, but was back in a number absolutely equal to just a primary ACL at 10 in the single stage. And then the ACL RSI that was so high in the slow producing group, the single stage was back at 65, is considered good and healthy. I'd like to see it at 90 or 95, but in the single stage it was about 80. But when the staged one happens, it took them a long time, and sometimes they never get their confidence back. So in some settings they return. Some settings I think they're like never going through this again, you know, with what I've just been put through. When you look at SANE scores, rate of graft re-injury, and at 2 years we don't have any yet. Somebody's going to re-tear probably, you know, return to sport or level of sport, infection, DVT, all that equal between those two groups. So the osteotomies did their self-reported scores, everything else were the same, re-injury was the same. So compared to matched controls, there was increased body weight, you know, higher rate of stage procedures, and some differences in graft choices when you scientifically look at this. You know, it's the largest sample for sure right now. We need a lot more. You know, a lot of this is still statistically underpowered to make absolute stuff, but I do think this is a part of what you're going to see more and more and more of, which kind of scares me because it's not easy, as you can imagine, to do this and have guys and girls get over it. But it can return their performance, and I'm going to show you several examples of that so you don't have to just believe me, and I hope I can get video to play. I think that one's just a picture. So, you know, but it really is something that's going to maximize our ability to decrease re-tear or minimize re-tear if you look at that. You know, the main thing I want to point, it is not a career-ending surgery, okay, for sure. And that's been the perception of it up to now. So I'll see if we can get these to play. So this is our first one in an elite athlete, and this is a women's soccer girl from Texas A&M. She's on the Canadian national team. She had a previous BTB, a slope of 17, and failed at 1 year or a little less than 1 year back on the field. This is just sort of showing her pre-op and post-op pictures. So she was at 17, returned, I think, to about 8, if I remember that. So in her, what options did we have? If I told her I could just redo it again and go take a contralateral patellar tendon or go take a ipsilateral quad tendon, she'd have retorn at a year again, you know, because we didn't do anything to address the problem. And it was a long talk. You know, family flew down from Canada, the whole bit, to do it. This is her now at here's her return to play testing. This is her at 6 months. And so you can read which knee it is, but I bet if you just watched the video, you couldn't tell me which knee it was. You can see all of her return to. Now, this girl is a baller, okay? I mean, she knocked it out of the park from day one. You want to talk about a rehab? Jackie's here. She was involved in it. She's a pretty amazing woman for sure. This is her in one of her first games back. And so I wish we had a video of her scoring, but tell me which leg it is when you watch her. You know, so this, she has to use both legs coming through this. And that's at about, that video's at about 14 months after this slow producing osteotomy. When you look at her performance metrics, her pre-injury vertical jump was essentially exactly the same, you know, 0.2 inches less. Her pre-injury peak power testing was only about 200 watts less. Her pre-injury top speed was exactly the same as when she came back after this. This is one of our running backs at U of H that tore his ACL in spring practice and walked in with a slope of 19 degrees. And he's a kid who was projected to be there 2 years and go to the draft. And he's got the mother from you know where, and we just had the talk, and I said, listen, I think if I just do a patellar tendon ACL on him, his risk of failing right about the time he gets to the combine is really high. And so if we want to do everything we can to decrease that risk, then we need to do this osteotomy at the same time. So he had a primary slope-reducing osteotomy, a 7-suture lateral meniscus repair, and a patellar tendon ACL all done at the same time. So at 6 months, this is him. Again, watch and tell me if you can figure out which knee it was, because you really can't. And all his numbers, even at 6 months, he had almost passed all the return to play, criteria that we have. Again, super athletic guy. Why is it showing up like that? This one. Yeah, so here's just, him running a 40. Same thing. Can you figure out which knee it is? I can. I've watched this video 100 times. He actually ran faster than his previous fastest recorded top speed, not by much, but 20.5 was his pre-injury top speed, fast guy, and ran 20.85 after the osteotomy at 6 months into it. His vertical jump was almost identical, 0.4 inches less, and his 40-yard dash was 4.6 seconds compared to 4.5 before. Now, as college football has it, he just went in the transfer portal and went to join Dion in Colorado, and I am so pissed we don't get to see him through his first season. But I was talking to Eric McCarty, the head team physician at Colorado at Herodica, said, hey, one of my favorite players just transferred to CU, and he goes, yeah, I know about him. He's getting over an ACL. I figured you did it. He's probably fine. I said, no, it has slope-reducing osteotomy and ACL. And he went, oh, crap. And I go, don't worry. And I showed him this. He goes, oh, okay, I'm fine. He goes, but if you hadn't talked to me, I probably would have failed him when he came in just because of the surgery he had had. So that's sort of the thought processes that are out there. It sounds really obvious, right? It's just not really embraced. And then this is same spring practice, same office visit from both of these players coming in at the same day. Is one of our defensive ends that had a primary ACL, another lateral meniscus injury, and a slope of, 19 again, and a big varus deformity. And you can't correct as much, so we were only able to correct him to 12, but corrected his varus 2. And this is him at 6 months. And you can tell because his brace is on, it's his left knee. But same thing, even at 6 months, he's almost passed. He's full on this summer. I didn't let him play this spring because I just didn't want to take the risk in spring. He did everything but contact and is cleared to play when camp starts. So anyway, thank you. I hope that was something new for you guys to think about. Anybody have questions?
So people online can't hear us, so you have to ask all your questions.
Hello.
Now I can hear you.
All right, take two. That's a little better. I guess it's related, but it's a little different more on my side. Is there any difference in your rehab protocols in regards to, like, what's the major difference if we do this procedure or if we notice it and don't do it on our end at the high school?
The only difference is the first 6 weeks with weight bearing right now. And so we were big chickens, the first few we did and made them non-weight bearing for 6 weeks. I now let them toe touch right away and progress to full weight bearing at a month. I think some of the techniques and newer osteotomies and stuff and newer osteotomy fixation things, we will be bearing full weight day one shortly. But right now, really the only difference, and Jackie, you can comment, Jackie's back in the back of the room, that's really these slope reducing things. We also don't want them to do an active knee extension for that first 6 weeks too. And I believe that's the only difference from a primary ACL. Is there anything different? Yeah. Right. Yeah, great. Yeah, anyone else?
Yes, right here. So I was keen on the posterior slope increase. I just want to ask, what other variables outside of the ACL tear that increases the posterior slope? Like outside of the complete tear of the ACL, what are those variables that
You know,
see?
the main risk factor associated with slope is tear ACL and primarily failure of ACL grafts. There is some thought that you can change the healing rate of meniscal repairs in high slope people by reducing it because the shear stresses are lower on it, but that's things that are getting thought about right now, and those are really the only two things. Because slope's just us, just like the difference in brown hair and blonde hair, you know. And there are a lot of people with high slope that are super athletic and never have an issue with it. So it's, I mean, Alton's mom came in and said, "Why don't we just go do his other knee right now, so he never has to go through this again?" I'm like, we are not there yet, you know, from that standpoint. Anyone else?
All of these patients were ACL only, correct? There was no meniscal involvement?
Oh no, there was meniscal involvement in most of them.
Okay, so did that change the outcome as well? Like,
No, it really didn't when we looked at it. So there was no difference in that in that part of their demographics. And you know what we did for the osteotomy made them go slower than we would for the meniscal repair. And so, and this isn't a really big group. I mean, there is going to be a difference in that, and meniscal healing isn't as you know, predictable as we want it to do, especially of the medial meniscus. You know, lateral meniscus, you can almost do anything to and it's going to heal. And most of these were lateral meniscus tears, and that association between high slope and lateral meniscus injury with an ACL hadn't been made yet, but I think it might be down the line. Anyone else?
We've got one question in the Zoom chat. It said that they have seen several ACL reconstructions that resulted in cysts and revisions. Would this LET improve that outcome?
Wait, would say that one more time?
Seen several ACL reconstructions that resulted in cysts and revisions. Would this LET improve that outcome?
The answer to that's maybe, you know, and so, you know, I think the indications that I went over, you would say yes. In a revision setting, even in the face of high slope, I think it should be done. Cyst formation and that kind of stuff is probably due to graft healing and unaffected by an LET and would need to be addressed and solved prior to doing that ACL. It's probably the best answer I have for that.
Do you have an example of the outcomes for a non-elite level athlete?
From a,
From a regular, like, not elite level athlete?
oh yeah, and so only 4 of those were fit that elite crowd of either D1 high-risk sports. You know, were basically the ones, you know, one was, you know, the girl from A&M also is on the Canadian national team. So, and she has returned to that also. You know, I didn't bring up that down the line, they almost all have that big plate taken out. They hate them, so there's another procedure down the line that slows them down for a couple weeks kind of thing. But all of that return to play stuff, most of it was done on just normal folks and normal kids. And, you know, we're going to have one that does bad. I'm afraid to find out when that is. We have a U of H kid that was graduating, slope of 22, that, and big meniscal injury that did a slope-reducing osteotomy, big meniscal repair, and at 4 weeks he looked awesome and said, "I'm moving back to California, I'll see you later." And he's just rehabbing himself, says he's fine, and I'm just praying that it doesn't end up with something bad, you know. What? Good? All right. I've been shut down. All right.
That was the last question. Good.
All right. Thanks, guys.
I got it. Hey, Dr. Lowe, you were wrong, though. Aren't all of them elite according to the parents? Absolutely. Okay, just making sure.